We're the Lindner Center of Hope. We're a comprehensive mental health center. We're located right here in Mason, Ohio. We've been around for 17 years and we serve the mental health needs of all ages, all diagnoses under one roof. And it's really important to us to provide this education to the community. We're passionate about raising awareness, increasing people's understanding of mental health issues, and hopefully reducing stigma and getting people connected with resources. So we're glad to be doing that this evening. Tonight, our presenters are talking about child and adolescent mental health. And we have Jessica Kraft and Lauren Neiser who are with us this evening. And they're going to kind of walk you through some ways to identify signs, look for resources, and then also discuss some treatment options. Thank you so much for being here again, and I'll turn it over to our presenters. Hi, thank you all for being here tonight. My name is Jessica Kraft. I'm a nurse practitioner. I've been at the Lindner Center for about 6 years now, and I mostly see people on an outpatient basis for medication management. And prior to that, I worked for 5 years as an RN for Cincinnati Children's, also on a psych unit. So pretty much all my healthcare experience is in psychiatry and with children and adolescents. I also want to have Lauren introduce herself too before we get started.
Hi, I'm Lauren Neiser. I'm also a nurse practitioner. I've been working in child adolescent mental health in various roles for about 14 years. I've been at the Lindner Center for 3 years, and I also see mainly outpatient, usually ages like 5, 6, and kind of throughout the lifespan. Thank you for being here.
Okay, so we wanted to go over our objectives first. So we have 3 for this evening. So the first is to identify 3 warning signs related to potential mental illness for children and adolescents. The second is to identify resources for help or support for child and adolescents. And third is to identify at least 2 different treatment options for children and adolescents with mental illness or mental health concerns. Now this is our table of contents. Pretty much everything on here we could do a full presentation on in itself. So as our title suggests, this is more of a general overview. So some of the diagnoses that we're going to be talking about this evening are depression, anxiety, ADHD, eating disorders, and then we'll be going over some of the different treatment options for these diagnoses, some general coping strategies, and resources available at Lindner and in the community. So I wanted to start off with this statistic. So this came from CDC, or Centers for Disease Control and Prevention. Nearly 1 in 5 children ages 3 to 17, or 21%, have been diagnosed with a mental, emotional, or behavioral health condition. And that statistic comes from the year 2021. So a little further breakdown on that statistic. So according to the CDC, anxiety, behavior disorders, and depression, these are the most commonly diagnosed mental disorders in children. Anxiety disorders are the highest, so that impacts about 11% of children ages 3 to 17 with current diagnosis. And further breakdown of that is about 9% males, 12% females. Behavior disorders impacts 8% of children in that same age range, 10% males, 5% females. And lastly is depression, which impacts about 4% of children. Breakdown is 3% males, 6% females. Now we're gonna start off by talking a little bit about depression. So I think a good question to ask at the start is, everyone feels sad from time to time or is going to have a difficult day, but when do we start to worry about a diagnosis of depression, and what are some of the causes for depression? So there's no exact answer to that question, but listed on this slide are several risk factors for depression. So first off would be family history. So if a child or adolescent has a parent or a sibling with depression, they're more likely have a higher risk of developing it as well. Another is conflict within the family, exposure to early adversity. Examples of that could be abuse, neglect, or significant losses. Problems with the primary friend group or at school, gender dysphoria or questioning, poor coping strategies, history of anxiety, a learning disability or ADHD. There's a lot of overlap in these mental health conditions, chronic illness, and lastly, history of brain injury or low birth weight. Now, as we're looking at diagnosis for depression, when child or adolescent is seeing a pediatrician or a psychiatric provider, usually they are referencing the DSM or the Diagnostic Statistical Manual of Mental Disorders. I don't want to get too nitty gritty in exactly every box you have to check, to meet diagnosis. So we're kind of going over the basics, and the associated symptoms and kind of what that would look like and like what you would see in the child or adolescent's day to day. But these first three are definitely core for a diagnosis. So how they're functioning, it has to be a change from previous functioning or their baseline. Second would be a persistent sad or irritable mood nearly every day for a period of 2 weeks or longer. And lastly, symptoms are causing significant distress or an impairment in their functioning. So that can show up as like issues with relationships, school, or work if it's an adolescent who's working. So in addition to those core three, we also have these additional symptoms or presentation and have to have at least 5 of these to go with diagnosis as well. So we'll go over some of these. So decreased enjoyment or pleasure. So hobbies or things that the child or adolescent used to enjoy or look forward to, they're just not getting that same enjoyment out of. Decreased socialization or withdrawing from friends and family. Changes in sleep. This can be too much sleep or too little sleep. Changes in appetite or weight. This can also be eating too much or eating too little, unintentional weight gain or weight loss. Psychomotor changes. This can present really differently. This can be really slowed movements or speech versus restlessness, fidgeting, agitation. This tends to be pretty observable to others. Low energy, feelings of fatigue, poor concentration, thoughts of worthlessness or guilt, thoughts of death or suicide. And some additional ones I added on there were negativity, irritability, picking fights with parents, unwillingness to try new things, being excessively self-critical, difficulty identifying positive things. Now, I know, one thing that might come up when looking at this list is, some of these things are normal things that an adolescent might present with, like irritability or changes in sleep. Those can certainly be common with that population. But there are, of course, symptoms here that also would not be considered normal, especially thoughts of death or suicide. That would always need to be something that would require immediate intervention. So I wanted to bring a little bit more attention to some of the warning signs for suicide, and you will see some of this overlaps with some of the symptoms of depression. So withdrawal from family or friends, sadness, crying spells, posts on social media suggesting feelings of depression or feeling isolated from others, an obsession or preoccupation with death and dying, giving away favorite things or discarding prized possessions, or verbalizing feeling trapped, having no reason to live, or like they're a burden to others. If a child or adolescent is verbalizing thoughts of suicide, it's always important to take this seriously. And if you have a child or adolescent in your life who's struggling with depression, it's also important to ask them and be checking in with them consistently. Next, we'll be talking about anxiety. So kind of like I said with depression, we're always going to have a sad day from time to time. Similar with anxiety, we're always going to have some anxiety from time to time. No one's guaranteed a worry-free life, unfortunately, but when are we concerned about a diagnosis? I also wanted to draw attention that since this is more of an overview, I'm talking more about generalized anxiety disorder here. Again, we could do whole presentation on anxiety. There's OCD, social anxiety, phobias, panic disorder, but we're talking more about generalized anxiety here. So three core criteria here. There's excessive anxiety or worry more days than not for a minimum of 6 months or longer, with regarding a number of events or activities. The individual often finds it difficult to control the worry or anxiety, and like depression, the symptoms are causing significant distress or an impairment in their day-to-day functioning. Some additional symptoms of anxiety, there's feelings of restlessness, being on edge, irritable, feeling like something bad is going to happen, or that impending sense of doom, avoidance of school or social activities, difficulty making decisions, excessive reassurance seeking, physical symptoms. This can look like headaches, dizziness, nausea, shortness of breath, pain. I'd say I see that a lot just kind of in my general practice, where a child or adolescent will be presenting with these kinds of symptoms that are physical, and they've been through all the testing with their primary care to try to rule out something medical, and they can't find anything. So that's when they end up in my office to screen for anxiety. You can also have difficulty sleeping, difficulty focusing in school, not eating enough, and again, thoughts of harming themselves. Next, we'll go a little bit over ADHD. So attention deficit hyperactivity disorder. This is a persistent pattern of inattention or hyperactivity and impulsivity that interferes with functioning or development. With ADHD, in order to meet criteria, the symptoms have to be present in at least 2 different settings. So this can be home, school, or work. Several symptoms are present prior to age 12. And lastly, there's clear evidence that the symptoms interfere with or reduce the quality of their social, academic, or occupational functioning. We have 2 different subtypes of ADHD, so it can be diagnosed with inattentive type, hyperactive type, or there is combination, you can struggle with both. So inattentive type, what this looks like is poor attention to detail or making careless mistakes, difficulty maintaining attention in play, school, or home activities. The child may look like they're not listening even when they're directly addressed. They fail to follow through, difficulty organizing tasks, activities, their things, avoiding tasks that require consistent mental effort, losing objects required for tasks or activities, distractibility, easily distracted by irrelevant stimuli, and forgetfulness in routine activities. The hyperactive type, this one tends to be a bit more obvious in the classroom. Excessive fidgetiness, difficulty remaining seated when sitting is required, like in a classroom. For adolescents, there can be feelings of restlessness. For younger children, it can be inappropriate running or climbing around the room. Definitely seeing that in my office as well. The child may be difficult to keep up with, look like they're always on the go or driven by a motor, excessive talking, difficulty waiting their turn, blurting out answers too quickly, and interruption or intrusion of others. Oftentimes, when we're looking into a diagnosis of ADHD, we are gathering information from a lot of different people, because again, as I said on the last slide, these symptoms have to be present in at least 2 settings. So it's very helpful to not just get information from the parents, but also the teachers. So we can get an idea of what this looks like in multiple areas. Last disorders I want to call attention to here are eating disorders. There are many different types of eating disorders, but these are the 3 that we tend to see most in practice. So that would be anorexia nervosa, bulimia nervosa, and binge eating disorder. So there are a lot of different risk factors for eating disorders, and we're just going to highlight a few here, between biological, psychological, and social. So biological, definitely at higher risk if there's a close relative with an eating disorder, if there's a long history of dieting behaviors, or a prior diagnosis of type 1 diabetes. For psychological, some common ones are perfectionism, emotional dysregulation, dissatisfaction with body image, personal history of mental health condition or substance use disorder. And lastly, social, weight stigma, teasing or bullying, limited social networks. So we'll talk a little bit more about anorexia first. So these are some of the core criteria here. So there's persistent restriction of energy intake or food that leads to an abnormally low body weight. The individual often has an intense fear of gaining weight or becoming fat or and they have persistent behavior that prevents weight gain. And they have a distorted perception or importance of body weight and shape. Some other associated features of anorexia would be obsessional preoccupation with food. Sometimes this can look like hoarding food or collecting recipes, fear of certain foods or restricted repertoire of foods, food-related rituals. Sometimes that can look like cutting food into really tiny pieces or refusing to mix different types of foods or colors on the plate, concern or anxiety about eating in public, specific exercise-related rituals, menstrual irregularities. The individual often has a resistance to treatment just in general and gaining weight. Perfectionism, depressed or anxious mood, need to control one's environment, and limited insight into the issue or core denial of the symptoms. The core features for bulimia, recurrent episodes of binge eating. I did want to give a little bit more of a definition of this because this can mean different things to different people. So how we're kind of defining a binge episode here is an excessive amount of food in a discrete period of time that would be more than the average person would eat. So other examples of that would be like 2 meals at a time or approximately 2,000 calories. After binge eating episodes, the individual has recurrent inappropriate compensatory behaviors. We'll talk a little bit more about those on the next slide, but that would be like intentional vomiting, excessive exercise in order to prevent gaining weight. And lastly, self-evaluation is unduly influenced by body shape and weight. So the associated features of bulimia, so the episodes of binge eating as we defined before, these often happen in secret. The individual often feels a loss of control during those episodes, and then they engage in the compensatory behaviors to try to avoid the weight gain. So that would be self-induced vomiting, excessive exercise, or misuse of medications like laxatives or diuretics. It's not uncommon for normal body weight or BMI with bulimia, but this certainly can vary. Not uncommon for them to drink excessive amounts of water, beverages with no calories, excessive amounts of mints, gum. Dental problems can be common, especially if the self-induced vomiting is the main compensatory action, and emotional dysregulation. We also wanted to talk a little bit about binge eating disorder. I feel like I see this more than anything else, and it tends to get less attention. So like bulimia, this has recurrent episodes of binge eating by that same definition. These occur at least once a week. But what's different here is that those compensatory behaviors, the intentional vomiting, exercise, misuse of meds, that is not present with binge eating disorder. And episodes of binge eating are often triggered by distressing emotions or environmental or interpersonal stressors. So some of the associated features here are similar. So still those episodes of binge eating that often happen in secret, feeling a loss of control during the episodes, and often having shame, guilt, feelings of despair after the episodes. Also not uncommon to see stealing or hoarding of foods, creating lifestyle schedules or rituals to make time for the binge eating sessions, and disruption in normal eating behaviors. So I'm going to hand it over to Lauren to talk a little bit more about some of the treatment options.
Okay. So now that we have an idea of what symptoms we're kind of looking for, what diagnoses we're kind of trying to treat, what does that treatment look like? So there is a wide variety of treatment options. We're gonna go over kind of, again, an overview of these, and we could go again into depth and do a whole presentation on just the treatment. But one of the first things that we can consider is medication. Another one is therapy. This can look like individual therapy for the patient. This can look like family therapy. This can look like play therapy, group therapy. There's lots of different options. Family-based support. So, especially with child and adolescents, it's important that the whole family is kind of involved in the treatment. So we want to make sure that the support system is also feeling supported. Crisis intervention, so there are, kind of as Jessica mentioned, crises that arise often related to suicidal ideation, self-harm, things like that. So how do we get help in the moment when we need it? And then lifestyle intervention. So, there's lots of different things we can do outside, of therapy and medication that can help us feel better and kind of set us up for success. So before we kind of talk about the medications we use to kind of treat these ailments and these symptoms, I think it's important just to kind of like give a brief overview on what these medications are kind of doing in our body and with our child or adolescent. So when we're talking about using medication, we're talking about balancing neurotransmitters in their brain. So neurotransmitters are just chemicals that our brain uses between its neurons to communicate with the rest of the body. There's three main ones that we kind of talk about when we're talking about medications to treat things like depression and anxiety. The first one is serotonin. It's probably the most common one when we're talking about how medication is gonna be used to treat these ailments. So serotonin is really important in regulating sleep, blood clotting, digestion, our temperature, our libido, our mood, our anxiety, lots of different things. And when we are seeing things like depression and anxiety, we tend to have a deficiency in serotonin in our brain. So that's sometimes where these medications come in. There's other ways to kind of help boost serotonin that are outside of medication. That includes like joyful, happy movement, being out in the sunlight, getting vitamin D, things like that. The next one is norepinephrine. So when we think of norepinephrine, this is the neurotransmitter that helps with our fight or flight response or kind of regulating our sympathetic nervous system. So it kind of responds to like stressful events, when we're feeling on edge, those types of things our norepinephrine is usually in play here. It also helps regulate things like mood, attention, memory, sleep. And again, when we have deficiencies in this neurotransmitter, we see things like depression, anxiety, ADHD. The last one is dopamine. So dopamine is kind of considered like our reward or pleasure neurotransmitter or like our happy neurotransmitter. It also helps with regulating like fine motor movement, mood, memory, learning, our emotions, attention. And again, we tend to see a deficiency in this when we're talking about things like anxiety, depression, irritability, anger, maybe even some aggressive behavior. Okay, so. Okay. So this is just an overview of the kind of types of medications that we use. So we have antidepressants, which can treat a plethora of symptoms, including depression, anxiety, OCD, things like PTSD or trauma symptoms. We have anxiolytics, which are anti-anxiety medicines. So again, focusing more on managing that anxiety. Stimulants and non-stimulants for ADHD. Mood stabilizers, again, can be treated or used to treat depression, anxiety, OCD, and then antipsychotics. So these can be also used for things like psychotic disorders like schizophrenia, bipolar, things like that. But we also use them off-label for mood, anxiety, OCD, and then some like aggressive behaviors. So when we're talking about using psychotropic medications with child and adolescents, it's important to have the discussion that most of these medications are considered off-label. What that means is there's no FDA indication for the use of some of these medications with things like depression for child adolescents or anxiety, things like that. There's lots of different reasons for them. One of the main reasons is that we have some ethical barriers to doing studies on children. Most studies that test medication are done on adults. Another kind of issue is child and adolescents, they metabolize medication differently. So that can change just some of the uses that we have. We might find that a medication that maybe we developed for one ailment might actually be beneficial for another ailment. So an example of this is like an anti-epileptic, sorry, or anti-seizure medicine we sometimes use for mood stabilization. So initially developed for something different than what we sometimes do that for. Another thing is like Jessica was kind of talking about, like, we might have kids who come in with symptoms that are congruent with depression, but they might not meet full criteria for major depression or for generalized anxiety, but they have symptoms that could be well managed with medication. So to fit in that little box to kind of have a check mark to use a medication just limits the ability and kind of progress it or perpetuate suffering. So all that to say, off-label use of medication, psychotropic medication in both child adolescent populations and adults is very common in psychiatry. So this is just a very vague list of medications that are available to us. They are the most common that we will see when talking about medications for children and adolescents. You might have heard of some of these. The first one are SSRIs, so that just stands for selective serotonin reuptake inhibitors. And all of these medications are doing is they are allowing more serotonin to be available in the brain, so it balances out that deficiency that we tend to see when we're having symptoms like depression and anxiety. So you might have heard of some of these. The names in the parentheses are their generic name. The name outside is their brand name. So Lexapro or escitalopram, Prozac or fluoxetine, Zoloft or sertraline, Vibrate or vilazodone, Celexa or citalopram is another one. That is the sister drug to Lexapro. SNRIs are serotonin norepinephrine reuptake inhibitors. So these are not only acting on serotonin, they're also acting on norepinephrine. These include Proseq or desvenlafaxine, Effexor or venlafaxine, and then Cymbalta or duloxetine. The next one is TCAs, which are tricyclic antidepressants. These are older medications that we don't tend to use as often just because the side effect profile is not always very nice. But one of the ones that we do use with child adolescents is called clomipramine or anafranil. This is mainly for OCD, so kind of in that anxiety disorder realm. Other ones that don't necessarily fall in any of these other categories are Remeron or mirtazapine. So Remeron is an atypical tetracyclic. It acts on norepinephrine and serotonin like the SNRIs. This is helpful sometimes if we have like sleep disruption or poor appetite, anxiety, things like that. It can be used in conjunction with some of these other medications. Another one is Wellbutrin. So there's sustained release and extended release of Wellbutrin. This is a norepinephrine dopamine reuptake inhibitor, so it is not acting on serotonin very much. There's some minimal action there, but it's mostly the norepinephrine and the dopamine. We use this a lot for depression, as maybe an adjunct to some of these other medicines, but it's also helpful for ADHD. All of these medicines have to be taken consistently, they have to be taken daily. They take a little bit of time to build in your body. So it's not something we're gonna take like the first couple of days and feel a ton of benefit from. It can take a few weeks to completely build in their system, but the progression of how they're feeling, treating those symptoms, hopefully get relief from those symptoms, it continues to kind of increase the more they take it. Anxiolytics are just anti-anxiety medicines. These can be, depending on the medicine, taken scheduled, like antidepressants, so every day. Or they can be taken as needed, so kind of just when maybe we feel on edge, or maybe there's a situation going on that makes us feel more anxious. The first one is Buspar or Buspirone. This is one that is scheduled. It can be taken up to 3 times a day, kind of depending on if we need it that often, how severe our anxiety is, that kind of thing. Hydroxyzine, or Atarax or Vistaril. So this is one that can be scheduled or it can be taken as needed. We use this one a lot, like at bedtime, sometimes because there's some sedation. It is an antihistamine. So like if a child adolescent is kind of laying in bed, their brain won't shut off. They're having lots of sticky ruminating thoughts. Sometimes this helps to quiet that so they can go to sleep. This sometimes works for panic attacks too. So if your child adolescent starts to feel like a panic attack coming, we can kind of take this to maybe interrupt that a little bit. Propranolol or Inderal. So this is one of those medications that's very much used off-label. So it's actually a blood pressure medication, but in small doses, we find it's really helpful for anxiety. We use this a lot for like performance anxiety, exam anxiety, social anxiety. So kind of taking it before maybe an event happens, it helps break that anxiety cycle and kind of calm those like physical symptoms that we get from anxiety, like my heart's racing, I'm having trouble breathing, I feel really dizzy, all those kinds of things. It quiets the nervous system, it lowers the blood pressure and the heart rate, so they feel more confident and comfortable to maybe go to a band concert or take an exam, that kind of thing. And then benzodiazepines, we use these pretty sparingly. So common ones are Klonopin or clonazepam, Ativan or lorazepam. You might have heard of Xanax too. These can just be very, very addictive, which is why we don't use them very often. But there are situations, like maybe if we have a child adolescent who's really, really struggling with panic attacks. The one problem with these they work really effectively and they take all the anxiety away. So sometimes when we get used to using these, we don't want to use our other medication to help. We don't want to use our coping skills, and we kind of just want to take a pill to make everything go away. So we try to avoid the use of these, but they do come up from time to time. Okay. In relation to ADHD, we have stimulants and non-stimulants. So stimulants fall in the category of methylphenidates and amphetamines. Methylphenidates include things like long-acting and immediate release Ritalin, Concerta, Daytrana, Focalin, amphetamines, Adderall, immediate release, extended release, and Vyvanse. The good thing with stimulants is they work quickly. So we don't have to have that kind of wait period that we have with some other medication. They work pretty quickly within the day, and we kind of know, do we feel like this is beneficial? They do have side effects and downsides. They definitely impact appetite. So sometimes, getting a child adolescent to eat adequately when they're taking a stimulant is a challenge. They can worsen anxiety. So if you have somebody who has a lot of anxiety, this could exacerbate that. They can cause like irritability, especially as they're kind of coming down off the stimulant a little bit or it's wearing off. And sometimes some mood fluctuation that we want to keep an eye out for. You can take breaks from stimulants, so like lots of child adolescents will, like over the summer, they might not take their stimulant when they're not in school, or they might take a break over Christmas break, that kind of thing. The biggest complaint I hear with stimulants from kids is I don't feel like myself, I don't feel as social, that kind of stuff. So sometimes they don't want to take them, which is maybe where some of the non-stimulants come into play. So another non-stimulant that we have is alpha-2 adrenergic agonists. So these combine to alpha-2 receptors in the brain, and they reduce, again, that sympathetic nervous response, which kind of quiets the hypermobility, some of the impulsivity, things like that. These are clonidine or Captay and guanfacine or Intuniv. These are also medications that they have to take consistently. We can't take breaks from this because they can cause dangerous fluctuations in blood pressure. And then we do use a handful of antidepressants for ADHD. and maybe less so like mood and anxiety, and those include Strattera and Quellbri. So these are both SNRIs, so similar to the antidepressants I was talking about on the last slide. These are again medications that they have to take consistently, they have to build in their system, so they're not gonna take it like day one like a stimulant and feel a benefit from it. When we're talking about stimulants versus non-stimulants, it's just kind of what do we prefer, what are some of the things we're trying to avoid, what is the goal? And kind of making the best decision based on those needs. Mood stabilizers, so these are usually used in adjunct with an antidepressant when we're talking about like managing depression and anxiety. They can be used as monotherapy or alone, but sometimes we use them in conjunction. So those are Lamictal or lamotrigine or topamax or topiramate. These are both anti-epileptic medications or anti-seizure medications. So again, an off-label use, but they sometimes are really helpful for things like OCD or major depression when maybe we're getting benefit from an antidepressant, but maybe not quite enough, and we feel like we just need something extra. Antipsychotics. So these are used a lot with kind of to relieve like rigidity or really sticky brain stuff. So when we're talking about like maybe as like an adjunct to OCD, if we are treating like an eating disorder where there's a lot of rigidity around food and body image, things like that, these can be used for in like autism spectrum disorder or oppositional defiant disorder, where we have like oppositional behaviors. These can be used for that. These increase both serotonin and dopamine in the brain. And these often work a lot faster than antidepressants. They do still take time to build in the system, but not usually as long as something like an SSRI or SNRI. These include Risperdal or risperidone, Seroquel or quetiapine, Abilify or Piprazole, or Zyprexa or olanzapine. We use Zyprexa a lot in anorexia nervosa treatment, because again, it helps with that brain elasticity, there's sticky thoughts about my body image and food and things like that, and it also helps with weight gain. These do tend to have, depending on the like what dose you're on and how you tolerate it, they can have more unpleasurable side effects. So like they can cause sedation. There's usually at least annual blood work that your child will have to do. So if your kid really doesn't like to do blood draws, things like that, that could be a limiting factor for these. And then we'll move to therapy. So there's lots of different forms of therapy out there. Two that we use quite frequently are CBT and DBT. So CBT is cognitive behavioral therapy and DBT is dialectical behavioral therapy. CBT focuses a lot on identifying solutions in the moment. It also talks about how our feelings impact our behaviors, impacts our mood, and how it's a triangle. It works on not dwelling on the past, kind of changing the way our thoughts are to change our behavior and our feelings. So for example, if a child adolescent is thinking, well, I'm worthless. Well, that's probably gonna lead to feelings of sadness or depression. It might lead to the behavior of avoidance or isolation from family. So this kind of therapy focuses on maybe changing that thought into a positive or kind of controlling what we can in the moment. DBT focuses on building skills for emotional dysregulation, reducing self-harm, and improving relationships. The major skills that DBT focuses on are mindfulness or being in the present, distress tolerance or managing emotions or situations without making them worse. Emotional regulation or understanding your emotions and interpersonal effectiveness. So maintaining relationships and how do we work within those relationships. A very focused DBT program is going to entail both individual therapy, group therapy, and then phone consultations. Not every psychologist or therapist or provider is DBT, like straight DBT therapy. They're usually DBT informed. So they're using DBT skills, they're walking through all the mindfulness and emotion regulation, that kind of stuff, but they might not kind of compose of all three kind of services that like someone who's like completely DBT informed and providing all DBT services. So if that's something you're looking for, it's just good to ask. So the kind of the difference between CBT and DBT is CBT is wanting to change those negative thoughts to change our behaviors, and DBT is more accepting emotions to change our behaviors. DBT tends to be good for things like personality disorders, depression, eating disorders, substance use. CBT is good for things like anxiety, depression, eating disorders, trauma, PTSD, chronic pain, health concerns, sleep challenges, or insomnia. Behavioral therapy involves things like play therapy, group therapy. It can even involve occupational therapy because we're wanting to find skills and develop ways to manage behaviors. And then family therapy can look like talk therapy as a group that's being facilitated by a therapist. It can look like family-specific therapy of like maybe the patient or the child adolescent is not involved in the therapy, but the support system is. Specific to eating disorders, there is a form of therapy called family based therapy, and this kind of works on giving empowerment to the family to kind of help the child adolescent work toward recovery. Lifestyle intervention. So there's things we can do outside of therapy. There's things we can do outside of medication to kind of treat some of the symptoms that we've talked about. The first would be joyful and mindful movement. So we never want to build a negative relationship with movement or exercise for our kids. So this can look like riding bikes in the neighborhood with their friends, or playing a sport, or being in dance, or even just having a dance party in your living room. Something that gives them joy and gets them moving their body. Managing stress. So I will say this comes up a lot more with my adolescents. So like maybe we don't take 6 AP courses, and we maybe take 2, and we don't have to get 100% in every class, and like managing our expectations so that we're not feeling stressed and on edge all the time. Building a coping toolbox. So this doesn't have to be a literal box, even though sometimes people find that helpful. But just building a repertoire of coping skills that they find helpful. So this can be things like having, and we're gonna talk about this in a minute, but like having coping cards, or maybe having a place in their room that they keep all their things that help them kind of regulate their emotions. This can be things that they even like keep on their phone, like a list of things that they find helpful. Sunlight. I know sometimes we all don't get sunlight this time of year, but getting out when you can, getting some vitamin D, maybe going for a walk when they can, whether that be with maybe the dog or the family. When we do get into like winter months, when it's dark at 5 p.m. and things like that, we maybe can't get as much sunlight because they're in school all day. We do sometimes recommend what's called a happy light. So it is a light that they sit in front of for 30 minutes in the morning, like maybe when they're getting ready or making breakfast, and it mimics sunlight. So it mimics and tells their brain they're actually out in the sun, even though they're just sitting in front of a light for 30 minutes. Another thing is checking vitamin D. So all of us are probably vitamin D deficient in the winter months, just living where we live. That can definitely have an impact on mood and anxiety. So making sure if we've kind of done other things that aren't helpful, kind of checking vitamin D levels as well. Limiting screen time. I'm sure this is a big one for a lot of people. It can be a very big conflict in many homes, but it's very, very important. So like setting up expectations, setting timers or limits on screens, making sure that they're not using screens an hour before bedtime. Things like that, finding other hobbies they can enjoy that aren't related to their phone or a tablet or a TV or a video game. Engaging in hobbies. So this one kind of ties to the screen time. So do they want to play an instrument? Do they want to be involved in a sport? Do they want to crochet? Do they want to scrapbook? Just finding other things that they can do when they maybe are feeling distressed, or they are feeling bored, or they can't be on their screens, to help kind of re-regulate how they're feeling in the moment. A strong support system. So this can look different for everybody. I think sometimes when we think about child adolescent support, it's kind of about like, oh, parents or their immediate caregiver, but this could be teachers, this could be a counselor, this could be a family friend, just anyone that they feel like they can go to and be honest with, and kind of let them know, hey, I'm not feeling great, or hey, this is bothering me. Just making sure that they don't feel isolated and that they, like, kind of like Jessica said, having these conversations that might feel icky about scary things, but it's really important to foster and house those conversations with whomever they feel most supported with. Consistent nutrition. This is another one that can be a bit of a struggle, maybe more with our adolescents, but or even our young kids who maybe just roll out of bed and want to go to school and they don't want to eat. But making sure they're eating at least 3 meals and 2 snacks a day. Kind of having conversations with them about, hey, if we don't eat consistently, this impacts our mood, our anxiety, how we sleep, how we focus in class. All those types of things, because their brains and their bodies are still growing, and nutrition is vital to that process and managing these things that we're talking about. Adequate sleep and rest, another one that can be kind of a tumultuous conversation. But again, making sure we're off our screens an hour before, make sure we're using our bed for sleep so that they're not like laying in bed all weekend on their phone, or that they're always doing their homework in their bed. That there is not a ton of light in their room, they're turning their lights off when they go to bed. That they're sleeping in their bed. There's lots of kids I have who like to get up and come into mom and dad's room and sleep on the floor, and that's not the best sleep for them. So just making sure that, again, we have a place set up for them, that they feel comfortable sleeping, and that they're going to bed at a regular routine time and getting at least 8 hours of sleep, if not more. All right, coping mechanisms. So I really like the idea of coping cards. So coping cards are exactly what they sound like. They're cards that have your coping skill on them. So when we are super dysregulated, we are super anxious, we don't feel like ourselves, our brain is not thinking, well, I should really practice some deep breathing right now. And your child or adolescent is not gonna have that thought and go to that immediately. So if we have coping cards that maybe they can decorate or they can laminate and they can keep in their backpack or in their room or things like that, and when they're getting upset, you could even redirect them and be like, hey, can you go get your coping cards and try a coping skill? And it's there in front of them, they help make the card, they know what it looks like, and it takes kind of some of the thought process out of it. This is helpful, especially with anxiety, because when our brain is in fight or flight mode, there's lots of norepinephrine going on. We react physiologically in the same way if we're worried about a bad exam score versus a bear being in our room. Our body is reacting the same way. And it's not, again, in that moment thinking about, oh, well, I should go get my stress ball and squeeze it. It's not in that frame of mind. So sometimes these coping cards are helpful. Trying lots of different coping skills. So making a list, there's lots of lists online that you can print off, kind of go through. Not every coping skill is going to be helpful in every situation. So it's important to practice lots of different ones. And then the next point is practice, practice, practice. So lots of my child adolescent patients come in, they're like, I tried deep breathing and it didn't work. And I'm like, that's great, I'm glad you tried that. And like any other skill that we're learning, we have to do it over and over again for sometimes for it to be effective. So just because it didn't work once doesn't mean it's not gonna work another time, and we have to kind of get used to doing it and kind of perfect it again like we would any other skill. Cognitive techniques we can use. So replacing a negative thought with a positive thought. So if they have a thought of, for example, like, oh, I'm so stupid, because maybe they got a bad exam score, maybe they felt like they said something silly to a peer, kind of switching that into a positive. And that can be something as simple as, well, I tried my best, or I just didn't understand the question, or I'm not dumb, I just need to study more, just something that takes that pressure and that negative self-talk off of them. Another one is focusing on what can be controlled. This is very helpful for anxiety. This is one that definitely takes practice. So when we do a lot of what we call future tripping of like, well, if I don't get the best grades and I don't get the best ACT score, then I'm not gonna get into college, and then I'm not gonna be able to do this, all these things that can happen that we can't control in that moment. What can we control in the moment? We can control how you're studying, we can control what classes you're taking, all these different things, but trying to kind of like pull back on that future tripping and, okay, what are the things in this moment that we can work on and control? And then radical acceptance. So radical acceptance is a skill where we kind of accept that things are as they are. It doesn't mean we have to like it. It doesn't mean that we have to be happy about it. We just have to accept things in the moment and work on how we kind of move forward or how we control the situation again in this moment, with accepting that it is how it is. This is another one that I think even adults find difficult, but especially child adolescents, so it's another one that takes practice. Deep breathing. So deep breathing is effective. Again, it takes practice. There's diaphragmatic breathing where we breathe from our diaphragm. There's 5-5-5 or triangulated breathing where you inhale for 5 seconds, hold for 5 seconds, breathe out for 5 seconds. These both slow the nervous system, which in turn kind of eases anxiety, slows our heart rate, slows our blood pressure. Another is grounding techniques. This is also pretty helpful for anxiety. So this can be things like naming colors or shapes in a room. This can be holding ice, which is called a tip skill. It could be dunking your face in cold water. It can be describing how a chair feels on your body, or excuse me, how the floor feels on your body. These are all things that help them come back in the present, and get them out of that headspace of this anxiety cycle of like, I feel anxious about something, well, now I feel the physical symptoms of anxiety and I feel anxious about the physical symptoms, and we're just kind of in this spiral. So these things help break that up and get them out of that cycle. Journaling, and journaling can look different for other people. Some people do bullet journaling. Some people want to write full sentences, some people just write words. It's whatever they feel like is helpful, but sometimes even just getting it out of their head and onto paper makes them feel better. So I encourage a lot of journaling. It doesn't have to be an hour-long journal, it can be 5 minutes. It doesn't have to be every day, but just when they're feeling distressed or feel like there's something that's bothering them, whether that's anxiety related, social related, family related, just kind of getting it out of their head. Positive self-talk. So again, kind of replacing those negative thoughts about yourself with something positive. Again, this takes practice. It's not something that's learned or kind of exacted overnight. This kind of ties into affirmations. So like saying good things about yourself, or finding affirmations online that you feel like might pertain to you or you would like to pertain to you. I usually have my adolescents and my children like write on Post-its or decorate their mirror in their bathroom or their bedroom with positive things. If they can't think of anything, sometimes I ask them to like ask family or friends, like positive affirmations about themselves, and then I have them reread them or say them over and over, because again, this is something that we have to kind of learn. It's not going to feel automatic when we're kind of just coming up with these affirmations. We might not believe them all right away. And then volunteer work. I like recommending volunteering. It builds connection both with the community and socially. It can give a sense of purpose. It can help them get tied to a passion. It kind of gives them exposure to how other people live within the community. And it also just releases like good, happy endorphins. So I think it's helpful, and there's many, many different ways that people can volunteer. Animal shelters and cat cafes are very popular with my group of kids. Eating disorder treatment, so we could do a whole presentation on this, but just like a general overview. The biggest thing is interrupting eating disorder behaviors, whether this be binge eating, restriction, purging, excessive movement or exercise. If this can't be done at home, sometimes this leads to a higher level of care where there's more containment. But this could look like, okay, you can't run cross country anymore because we kind of have to get your eating back on track. Or this could look like, and this is more of an extreme example, but like you just take the bathroom door off so you can't purge, that kind of thing. Managing nutrition. So eating disorder treatment is very much a team effort. So both with the support system or the family, there's always a dietitian involved or dietary support, a therapist or psychologist. There's medication management and medical management, which are sometimes combined, but it's all of these people working together to kind of help this child work toward recovery. So the dietitian usually will start out to kind of no matter what the eating disorder is with a meal plan, and kind of what the expectations are around their meals and nutrition. And then the goal eventually is to work them toward intuitive eating, listening to their body when it's hungry, eating what they want to eat when they want to eat it, all that kind of stuff. Increase in medical monitoring. This can be dependent on the severity of the eating disorder, the type of eating disorder, but a lot of the time this involves pretty frequent lab work, EKGs, vital signs, blind weights, things like that. Again, sometimes depending on the severity, this might lead to a higher level of care to be involved just for really kind of close monitoring of these data points. Individual and family-based therapy. So again, this involves the patient having therapy, but also the family being involved. So I talked about earlier about FBT. This kind of looks like family kind of taking over the meal plan initially, when they're in the early stages of recovery, making sure the family feels empowered to do that, feels supported, that kind of thing. And then appropriate level of care. So like I mentioned, it's gonna depend on the severity of the eating disorder, if we can interrupt the behaviors at home or we cannot. Is there a higher medical risk? So like, do they have high or low blood pressure, high heart rate, things like that. But eating disorders can be managed at multiple levels of care. And speaking of levels of care, so I'm just gonna give like a very brief overview of what each level of care looks like. And then Jessica's gonna go into more detail of like what those look like related to the Lindner Center. So inpatient is crisis stabilization. It's usually related to a safety concern. So like maybe someone is having suicidal ideation or they're self-harming. They might be running away from school or running away from home and we can't kind of contain them. That's when inpatient would be appropriate. This is usually a 24/7 monitored unit. It's locked. Rules tend to be more rigid just for safety. But again, because it's crisis stabilization, the stay is pretty short. So usually within like 3 to 5 days. And then they kind of go to a different level of care back to outpatient. Residential is more of a much long-term usually kind of stay. So they usually go to live at a facility for very intense therapeutic work and support. Sometimes they could live there for weeks, months, even years. Again, this is usually, or it is a 24/7 staff supported unit. They're usually working on something very specific. So this is something you might see with like substance use disorders, eating disorders, things like that. PHP, which is partial hospitalization program. So this is a day program. The hours vary depending on where you're doing PHP, but typically they come in the morning, they leave in the early afternoon. They go home and practice the skills they're learning in PHP. They learn to manage their symptoms at home when they're not there for that therapeutic support throughout the day. This also kind of varies on length, but typically like 7 to 10 days is a PHP admission. It usually involves group therapy, individual therapy, and then medication management of some sort. This can also be a step down from a higher level of care. So if someone maybe goes into inpatient for crisis stabilization, we get the crisis kind of stabilized, maybe their medications figured out, they can step down to PHP. A lot of PHPs also will incorporate the school. So they might do like the first 5 days of PHP, they don't go to school, but then they start to incorporate, okay, you go back to school for half day, or you might go to school for a full day and then come back to PHP the next day. How did that go? That kind of thing. Intensive outpatient program or IOP. This is a step below PHP. So this, it depends on the frequency again, usually 3 to 5 days a week for a couple hours every night, tends to be in the evening, some are during the day. This again focuses on therapy, group therapy. There's not usually medication management at this level of care. So you might be seeing like their outpatient provider for medication management, but they're doing more of the like intensive therapy work in IOP. And then again, this tends to be a step down from maybe like PHP or even a step up from outpatient if maybe they just need a little bit more support. Outpatient is your typical check in with a therapist weekly, bi-weekly, monthly, depending on how much is needed or recommended. Checking in with a med management provider once a month usually. This can also include things like occupational therapy, speech therapy, play therapy, behavioral therapy. Those are all outpatient services as well. And then crisis or immediate intervention like the emergency room. So again, these tend to be safety risks. So suicidal ideation, self-harm, fleeing, being aggressive, substance use, that's pretty severe, that kind of thing. This usually, depending on maybe what they're being seen in the ER for, can lead to something like an inpatient admission. Again, depending on the severity, sometimes they will say, inpatient might be too much, we can refer you to PHP or IOP, or maybe even just back to your outpatient.
Okay, I'm gonna be talking a little bit more about the resources that we have specifically at Lindner. And then Lauren will be going over a couple more community-based resources, and then we'll be wrapping up with questions. So at the Lindner Center, we have a team of child and adolescent providers who do comprehensive diagnostic treatment and services in a comfortable and therapeutic setting. Our care is very individualized and provided with a focus on the family involvement. The family education and participation is really essential to the success of the child or adolescent in their treatment and recovery process. So these are some of the services we offer, and I'll be discussing each of them a little more in depth, but we have outpatient services, partial hospitalization, inpatient hospitalization, group therapy, and TMS. So outpatient services, as Lauren said, this typically looks like medication management, therapy, and testing. So we have all of these resources at the Lindner Center. So we have providers who do the medication management side of things, individual or group therapy, or more in-depth neuropsychological testing. So we have resources that are either in person or virtual, depending on the preference of the family. And we treat multiple diagnoses, including but not limited to depression, anxiety, bipolar, eating disorders, OCD, substance use. So group therapy, I know the people who are here in person, we have the more thorough list of all of our groups, but these are the ones that we specifically offer for adolescents. So as Lauren was talking about, we have DBT or dialectical behavior therapy. This is for ages 14 to 18. And we also have RODBT, which is radically open dialectical behavior therapy. So there are a lot of similarities between DBT and RODBT, but RODBT tends to be better for those adolescents who have more over-controlled coping tendencies or really high standards perfectionism, and it can help with relaxing some of that rigidity and just helping them feel calmer. We also have a peers group for ages 13 to 17. So this is more for teens with social skill difficulty resulting from diagnoses like autism, ADHD, or social anxiety. I have on the slides our website information and phone number if anyone is interested in pursuing any of those groups. Now, TMS, we have not really discussed in depth tonight, but this is transcranial magnetic stimulation. So this is sometimes a treatment that will be recommended if a child or adolescent has tried, sorry, not child, just adolescent. If an adolescent has tried multiple medications or different therapies and haven't found it helpful. So this is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain to improve symptoms of multiple diagnoses, but primarily depression. As of now, TMS is approved for treatment of depression in adolescents ages 15 and older. So we're very lucky to have providers at Lindner who offer that treatment. I also have the phone number and website info on there as well. For hospitalization at Lindner, we have a fantastic partial hospitalization program. So as Lauren said, this is a day treatment program where they come in the morning and leave in the early afternoon. Average length of stay is about 10 days, but it really depends on each kiddo and what they really need. I refer patients to partial hospitalization all the time. I feel like it's a really great level of care where if you need more than what you're getting an outpatient, but you don't quite need an inpatient hospitalization, and can also be very helpful for things like school refusal. So they have that school teacher component, who helps act as a liaison with the school and create a school transition if needed. It has a social work component too that provides a lot of education for the family and conducts family meetings, all of that. Inpatient hospitalization. So the inpatient unit for adolescents at Lindner is run through Cincinnati Children's. They lease a space in our building, and that is a 16-bed inpatient unit. So as Lauren said, they do the crisis stabilization. This tends to be a pretty short stay, and this is a locked facility. The number I have on there for that is the Psychiatric Intake Response Center, which is a 24-hour line through Children's. The other thing I did not add to this slide because it was not open yet when I made these slides is the intensive outpatient program. We do have an intensive outpatient program for adolescents that opened at Lindner just this month. So for the people who are here in person, we have a flyer on the table with more information about that. It's 3 days per week and it's like 3:30 to 6:30, so for after school. But you can also get more information about that by calling the number for partial hospitalization. Alright,
so what are some family support resources or groups? So the National Eating Disorder Association, or NEDA, is a great resource for families or child adolescents struggling with eating disorders. They have lots of family support groups. There's also a family support group at the Lindner Center. But this is just a great overall resource if you have questions or you feel like you need more answers or other people to kind of talk through what you're going through as well. The National Alliance of Mental Illness, or NAMI. So this is again, nationwide kind of support network. They again have lots of resources, whether it be support groups in your area, just information in general on mental illness related to child adolescents, support groups, support lines, things like that. It's also a wonderful resource. The Substance Abuse and Mental Health Services Administration, they have a behavioral health treatment services locator. Unfortunately, at least in this area, there are limited resources for child adolescents with substance abuse disorders. So this can be a good resource if you're having trouble finding a provider or a treatment program. And then Other Parents Like Me. This is actually a social platform that's specific for parents with children or adolescents that have mental health challenges or ailments. It's kind of a space to, again, get support, talk through what your experience is like, kind of get to know other people that are going through something similar. Other community resources outside of the Lindner Center. So this includes Cincinnati Children's Hospital Medical Center. They have all levels of care. Like Jessica said, they have an inpatient unit at the Lindner Center. And then if you need like immediate assistance, we recommend calling their PERC line. You can call that line if you have questions about what level of care that your child or adolescent needs, if you don't have a provider and you need resources, if you have general questions about how your child or adolescent is presenting, they're a great resource. And again, they can give you referrals. They refer to Lindner, they admit internally. They can refer to other, again, eating disorder, maybe substance use, treatment facilities, things like that. Specific to eating disorders, Eating Recovery Center is a great resource. So they have all levels of care all across the country. Unfortunately, recently their Cincinnati location closed. But they do have locations in like Chicago, Texas, Denver, and again, all levels of care. There's one on here that I didn't put, Astor Springs. It's more for adolescents, but they also have PHP and IOP for eating disorders. NAMI again, which again is a great resource for families who need support or just need information. United Way, our local chapter 211. This is a great resource for, again, referrals, support groups. They have mental health crisis hotlines for adults and child and adolescent. They have resources to substance use treatment, resources for things like food, if that becomes a scarcity for your family, those types of things. Insight is specific to child, adolescent, and even adult grief support. So if your child, adolescent is going through grief, needs more support around that, Insight could be a good option. The Anxiety Center, they also have multiple levels of care for child, adolescent. They treat exactly what it says they treat, so anxiety disorders, so generalized anxiety, phobias, OCD, social anxiety, things like that. And then substance use, again, some of the treatment options for substance use in our area are limited, but ASAP is specific to adolescents struggling with substance use disorders. So they're a really great resource. They have multiple levels of care as well. Any questions? Yeah.
Yeah, I just have a question. So, you know, like early on, we mentioned like children mentioning death. How do you determine like clinically when that has kind of crossed the Rubicon of like curiosity versus like actual internalized feelings, like wondering what death is like for them?
Yeah. So for the people who are online and might not have been able to hear him, he's asking how when children kind of talk about death, how we kind of differentiate clinically between maybe thoughts of suicide and maybe just being curious about death. Is that right?
Correct.
Okay. So do you want to answer? Okay. So it is developmentally appropriate for kids to ask about death, especially if there's a death in the family or a family pet dies or something like that. What we would do to differentiate between, okay, maybe there's just some curiosity around that versus we're worried about their safety, is asking things like if they have a desire to die, if they've thought about how they want to die, if they're unhappy and feel like that would make them feel better. Things like that, that would be more of a warning sign than maybe just talking about death in a general sense, or maybe asking questions like, oh, is so-and-so gonna come back? Those types of things. Do you have anything to add?
No, I think that's good.
Does that help?
Yeah. Thank you.
Okay, yeah, of course. Yeah.
I do have a question. When it comes to family history, like this, with schizophrenia or bipolar disorder, what does diagnosis look like for those? I mean, when it comes to Lindner Center, I know that when you go to a family doctor, at least it's been my experience, you just go to your GP,
Mhm.
they immediately want to just put them on medication, they just assume. Or I feel like they just assume, there's not really a very thorough check if
Mhm.
you are dealing with one of those symptoms, diseases or diagnosis or not.
Mhm.
What's it look like at the Lindner Center as far as diagnosing that?
Yeah, so the question was, as far as family, if there's a family history of something like schizophrenia or bipolar, what does that kind of look like from an assessment standpoint? Do you want to take this?
Yeah, sure. So I would say it depends a little bit depending on, who you're with, so for instance, for me, so I'm a psychiatric nurse practitioner. So when I see someone for a first visit, I'm doing a thorough psychiatric review of symptoms. So we're going through, symptoms of each kind of general diagnosis. I would say with children and adolescents, schizophrenia and bipolar can be a little bit harder to diagnose. Those do tend to show up later in life. But if we know there's a family history, that's definitely something we want to keep a closer eye on, and be mindful of the medications that we're prescribing and things like that. Like I said, sometimes there's more detailed neuropsychological testing. So sometimes if I get someone in for an appointment and diagnosis isn't as clear to me, sometimes I'm doing additional screening tools, I'm talking to additional family members, or sometimes I will refer for that more in-depth neuropsychological testing with a psychologist. But for especially children and adolescents, as Lauren was saying, with some of the treatment options, the side effects can be a little hefty with those medications. So I really like to be really sure of diagnosis before I'm using one of those medications for a child or adolescent. Does that help? Does that answer the question?
That helps. I think it's probably more on the family end that you start thinking those directions, so you know that it's part of the part, that it runs in the family. So I just know that they read it, when we broach the topic with general practitioners, it's just like them on medication of some sort, and whether it's doctor those or not, I don't know, so.
Right. And I know the comfort level too with general practitioners is going to vary. I know a lot of times pediatricians will be comfortable prescribing medication for depression or anxiety, but sometimes if it's getting a little more complicated than that, sometimes they will refer to psychiatry. But I know that definitely varies quite a bit depending on the individual provider.
Now, if it is part of the family, it's one of those two, especially bipolar, is something that's within the family. Is it common? I know this sounds silly, but for children or adolescents to mimic that behavior, or can some of the learned behavior, not so much actual disorder? Does that make sense? I'm sorry. That'll be my last question. I'm sorry.
So the question was if there's a family history of something like bipolar, or are children learning to mimic that? I wouldn't say so, at least from my experience. It's also like Jessica said, important to like have collateral from like maybe other family members, or like maybe a person who treated someone in the family with bipolar or schizophrenia. Because also sometimes like bipolar sometimes is misdiagnosed. So is it really bipolar that we're kind of looking for? Is it something different? Is it a different mood disorder? But we never assume just because someone in the family has schizophrenia or bipolar that your child presenting maybe with like erratic behaviors or things like that also has bipolar. There's lots and lots of different assessments we can do, like Jessica said, lots of different testing. And then again, it's clinical experience, it's collaboration, it's talking to teachers, what are they seeing? Because a lot of the times when they come into our office, we're seeing a tiny snippet of their presentation and their life. So it's helpful to get additional information from people maybe that they see on a daily basis. So we never assume just because you come in and say like, oh, grandma had schizophrenia, we're not just assuming that that's something that's gonna pop up. If that helps, yeah. Yeah.
How we as a parent can handle the situation when our teenagers, they don't want to collaborate or cooperate. Because just sharing something, my daughter place the counselor in the school, therapist, and even the psychiatrist who's going to the appointment seems to be okay, good. And then in some moments, we realize that she is not doing that good. But she just want to get out of the therapy, and she plays it professional. She has become a professional also with that. So, how to manage that, because she doesn't want to talk about everybody.
Yeah, the question was kind of related to, what do we do when our child or adolescent doesn't want to talk about kind of what they're going through with the professionals and they go in there and they say they're fine. We get this all the time of like, I'm fine, everything is wonderful, I don't need to talk about anything. And that's sometimes where like maybe a one-to-one family session comes in of like maybe where the therapist or the provider meets with you individually without your adolescent and gets an idea of what are you seeing at home. And then maybe a lot of the times with adolescents, it's finding someone that they feel comfortable with and can build rapport with, and sometimes that takes a little bit longer than maybe an adult. But someone they feel open with. But again, kind of getting your point of view or again, a teacher's point of view to kind of supplement maybe what they're saying, because a lot of the times they don't want to tell us, I'm sad, I'm depressed, I'm having these really scary, unsafe thoughts, things like that. So again, it's helpful, especially with child adolescents, to have the whole support system involved to kind of give us a better picture of what's going on. But we deal with that all the time, unfortunately. You made me laugh.
Yeah, I think the only other thing I would add to that is, sometimes I try to change the structure too of the visit to make sure the adolescent is most comfortable. Like, sometimes I'll see them one-on-one for the first half of the visit and then bring the parent in. Or, I sometimes have kids who are just so anxious, they want the parent there the whole time. So, sometimes just trying to change the approach a little bit of how are we interacting with them, and I try to remind them, like, I'm on your team, I can only help you so much if you've got to share with me, but what can we do to make you feel more comfortable and like you can share?
I do have one question in the chat. People wanted like to know, what is the referral process in order to come to the Lindner Center?
Okay. So I would say calling the main outpatient line, which I know we have that number in our slides and we have on the resources there. So it's, what is it? 536 0570. So that's our outpatient line. So that's really going to be your first point of contact to share like what it is you're looking for. So whether that be you're looking for a medication management provider or a therapist, or you're looking for neuropsychological testing or PHP. So our support staff, they'll kind of find out what exactly are we looking for. It might be multiple things. And then they will collect more information. At the Lindner Center, we try really hard to match, like, what's the, if you're looking for a therapist or med management provider, we want to get you matched with someone who's potentially going to be a good fit. So are you getting a provider who likes to work with that diagnosis? We want it to be very personalized. So they're going to ask you some questions about, what's going on that's leading up to the referral. Do you currently have any providers? You on any meds? They'll go through all those questions with you, and then they'll send it out to the team, and then go from there.
Share more about TMS, transcranial magnetic stimulation. Like anything. In what situation would they recommend that and penetrated by that?
Yeah, how long is that kind of therapy?
So the question was about TMS and when that would be appropriate, what that kind of looks like, how long it is. So like Jessica mentioned in the presentation, right now it's only FDA approved for depression, and that's pretty new. But a lot of the times, when maybe we've tried different medications and we didn't get the benefit that we were looking for, or they have side effects and they didn't tolerate multiple different medicines. They've been in therapy, they've tried different modes of therapy, and we're just not kind of getting traction and, relief from their symptoms. That's sometimes where TMS comes in. So TMS, they come in for the first session, which tends to be the longest. And they do what's called a brain mapping. So the adolescent sits in the chair, they use the magnetic machine to kind of map the area of the brain that they want to focus on, to treat the depression. And then when they come in for subsequent treatments, they tend to be very short. So depending on the patient, like anywhere from 3 to 9 minutes. It is pretty labor intensive in the beginning. They have to come every day of the week, for usually like 6 weeks or more. So it can be pretty intensive. The good thing is like, there's no anesthesia, there's no like sedation, they don't feel groggy or gross after. They can go to school immediately after. And there are some patients who have to come back for maintenance at some point, like maybe they just need to like come back and do a couple weeks of like a refresh. But again, this would be in situations where we've done lots of other things that we would recommend for things like depression, and we're not seeing the relief from symptoms that we're kind of going for. Does that help?
Yeah.
Okay.
So why wouldn't they try that first before medication? Unless there's bad side effects from it.
There's not typically, the main side effect that I've at least heard is like maybe some scalp irritation where like the magnet was. But again, sometimes with child adolescents, we don't have a lot of research and studies in that population just for the ethical reasons. So there's a lot more research around things like medication, and therapy and things like that versus doing TMS. And again, because it's so labor intensive at the beginning, it's not always feasible for everybody. Anything you would add? Okay, that's good.
Excuse me, I had
Yeah.
a question about, thank you so much for having this resource.
course.
And, these community resources, the adolescent in my life who has struggled with, mental health and, has been diagnosed, bipolar. And they are reaching that age, they're 17, about to be 18.
Mm-hmm.
And I'm wondering about, services that are available as they transition into being 18 and a adult.
Mm-hmm.
And if the, all these resources are available
Mm-hmm.
to them as they transition to, 18 and above, and through this time of transition in their lives,
Mm-hmm.
trying to learn best way to support them. And have resources available to them. If we need to use them, if they need to use them.
Mm-hmm. Sure, yeah, okay. The question was about kind of adolescents transitioning to that 18 young adult, kind of timeframe. Are the community sources that we kind of listed still available to them? The answer is yes. The one that could be not maybe as accessible is Cincinnati Children's. If they have had providers established there as an adolescent, they tend to keep seeing them into their early 20s. But that's not always, that they might not take them kind of coming in from the get-go at 18. But every other resource that we've kind of talked about usually goes into at least young adulthood. Because we all know 18-year-olds are not adults. And they do still, they need support. They need support from their families or their support system. So yes, like things like Eating Disorder Center, this ASAP, NAMI, NIDA, all those places, there are resources there for child, adolescent, young adult, and adults. As far as supporting them through that transition, I think just being there in a way that they feel like they need you. I think reflecting to them that it's normal to feel like even though they're an adult and they have to fill out all the paperwork and answer all the questions and things like that, like they still are new to this transition. They are still an adolescent. Their brains are still developing. There can be changes, but that you're there for support, and are there to kind of help them find the resources that they need if maybe they're kind of running into a barrier or brick wall. Does that help?
That is very helpful.
Okay.
Yes, thank you. And then I would ask,
Yeah.
around with the TMS,
Uh-huh.
that is, once they transfer, do you know, still as the brain is developing, has that treatment been helpful for young adults and then adults? as
Yes.
well?
Yeah.
Okay.
Yeah, I would say even more evidence for that treatment for adults than there are for adolescents. And the only other thing I was gonna add in addition that Lauren said is that when they turn 18, finding resources sometimes gets a little easier. You know, there's much more limitations in finding providers for therapy or med management who see children and adolescents. So honestly, the door just opens up so much when they turn 18.